Welcome, ladies. Welcome, Faith, Martha, and Vicky. My name is Esther Mbogwa Kimemia, and I'm really glad to have you here today. So today we're talking about other cousin of endometriosis, and it's a little understood cousin, and there are a lot of myths and a lot of misconceptions about adenomyosis as well. Every time you hear adenomyosis, one of the things that you hear is you should have your uterus removed, and then they mention hysterectomy, and we're not usually sure what should be removed and what shouldn't be removed. So this morning, I am excited to have my friend and Dr. Swabra, here to share with us more about adenomyosis, about hysterectomy, and about the Mirena IUD as well. So we'll welcome her and then we will start. I have a series of questions, so she'll present and then we'll ask the questions. If you have other questions, please put them in the chat box. I think we can unmute our mics at the end. Karibuni sana.
Sante. Hi everyone, my name is Dr. Swaleh. I'm an obstetrician gynecologist in Mombasa. So today we shall be talking about adenomyosis. Usually we hear a lot of endometriosis. I think she's like the most glamorous cousin of adenomyosis. Adenomyosis is not known about. We do not know anything, we do not understand anything about her, and yet she is real and she causes us a lot of pain. So Karibuni, if you have any questions, just save them for last so that we'll keep enough time for that time so that we can keep answering all the questions then. Yeah. So do I start the presentation?
Yes, you can
start. Okay, let me try and share my screen. Allow me to share. Good.
We should be able to now.
Yeah, let me try doing that. Easy computer, easy.
Okay.
Okay, so I don't know if you can see my screen.
Yes. Yes, we can.
So I picked this off a foundation that deals a lot with adenomyosis. It's just like a guide so that we can talk about it, okay? So basically, what is adenomyosis? So adenomyosis, I have my uterine dummy here, so I'll keep demonstrating as we go, is when the endometrial layer, okay, invaginates into the myometrial layer. I know, it sounds like a lot of English or a lot of science, but if you're looking at the uterus, okay, the inside layer that bleeds every month, that is the endometrial layer, okay? The part that every month is shed off. And then the muscle layer just adjacent to it, just next to it, is a muscle layer, what makes the bulk of the uterus, okay? So every layer is usually very distinct, has distinct function. For example, the endometrial layer is very, we call it secretory, meaning it can secrete blood, it can respond to hormones, it has glands, and all those things. The myometrial layer doesn't have all those things. So what happens when the endometrial layer enters where it's not supposed to be into the myometrial layer? Imagine the same function that it keeps doing at the endometrial layer, it now does at the myometrial layer. So that's a trouble with adenomyosis.
We can't see your uterus, so you might have to explain as you're holding it after.
Okay, let me do this.
Okay.
Perfect. Okay. Now you can see my uterus?
Yes, we can.
Okay, so this inside layer is the endometrial layer, what you see as red, and then the layer adjacent to it, which is now the bulk of the uterus itself, yeah, is a myometrial layer. So when we have this layer seeping inside into the myometrial layer, that's where the trouble is. So that the functions of endometrial layer, the bleeding, the inflammation, the secretion of hormones now happen at a location that is not supposed to be. So I have to distinctly separate endometriosis and adenomyosis, because for those of you who understand endometriosis, it's also the presence of an endometrial layer, but this time outside the uterus. So basically, adenomyosis is this dot you see. You see the black dot you see now here? This is the endometrial layer outside the endometrial layer, now inside the myometrial layer. Adenomyosis will be same thing, but now not on the uterus, on something like the ovary, somewhere there. Am I making sense?
Yes.
Yeah, perfect. So what's the problem then? I mean, here is endometrial layer. It's not supposed to be where it's supposed to be. It's somewhere else. There's trouble because if it continues doing what endometrial layers do inside of the myometrium, then there's trouble. So all the inflammatory processes during your period, there's a lot of inflammation going on. There's a lot of shedding of blood going on. Now imagine all that happening inside a muscle. So that's where you get all the pain because there's a lot of inflammation going on. There's change of a muscle consistency from what we know of a muscle to something very fibrous, very hard, because all these things are happening where they're not supposed to be happening. Now, there are many risk factors. So I'll go back to sharing my screen now.
Okay.
There are many risk factors to adenomyosis, but we can summarize and boil it all down to presence of estrogen. Okay, people who have high estrogen levels, they've done studies and they found out that people who have very high estrogenic levels, okay, are more prone to adenomyosis. There are other kinds of people who have had more than what we call the normal number of babies, what we call multiparous women. So we're talking about more than 4 babies, and there's no shame in having 10, okay? But I'm just saying, the more babies you have, the more likely that you're going to get adenomyosis. Why? Because with childbirth, every time you deliver, there's going to be reorganization of layers around. And so childbirth, we know, causes a lot of trauma to the uterine cavity. And so the endometrial layer might seep into the myometrial layer. Procedures done into the uterus, for example, dilatation and curettage. For example, if you procure an abortion and it's done in a haphazard manner, and and in the process of scraping off a pregnancy, someone pushes a inside layer into the muscle layer. So that can also predispose you to adenomyosis, okay? Most of it is highly not understood. So usually we just attribute the risk factors to the development of what? Adenomyosis.
Okay.
So fine, we're talking so much about it, but why adenomyosis? Why are we talking about it today? Because it has signs and symptoms that cause a lot of pain, are very rampant actually, and if you had not thought of adenomyosis, you go around treating other things, okay? So the most common symptoms, as you can see, usually are very heavy, painful. Actually, the key word here is painful, leave alone the heavy. There are other causes of heavy periods more than adenomyosis. But the key thing in adenomyosis is the periods are extremely, extremely painful. And then usually the PMS, which is a premenstrual syndrome. So those are the feelings you usually get, the side effects of people, some people have periods that are just extremely painful. Before their periods, they have mood swings, they have cravings. So all those signs and symptoms are clustered into what we call the PMS. So PMS usually is exaggerated in adenomyosis, okay? So fine, you have adenomyosis. How then do we confirm that this is adenomyosis? Before I even move to confirmation and diagnosis, probably another thing I will add is there is a woman who comes in with a recurrent miscarriage over and over and over and over again. So at some point, the gynecologist should stop and think, do we have adenomyosis? Because here is a uterine layer that is not quite cushiony and nice and supportive of a pregnancy. It has all these inflammatory changes. It is a very harsh environment to a new embryo, okay, to a new baby being implanted. And so that environment, that layer could easily not support implantation, and you could end up losing the pregnancy. So yes, diagnosis, I will go back to basics here. Diagnosis is basically examination, okay, taking of history. When you go visit your doctor, the questions that they ask, it is usually not just mushene. That is proper history taking can actually tease out adenomyosis. The questions that will come up is, how many pads do you use? What is your pain level from 1 to 10, okay? So usually we know the expected answers around a normal period. Are we still together, or I'm talking to myself?
Yes, we are together.
Okay, perfect.
Yes.
So, okay. So a good history taking is paramount in the diagnosis of adenomyosis. Then comes the examination, of course. How then will I conclusively examine you for adenomyosis? In the exam, keep in mind that as I examine you, I am trying to find, the proof of adenomyosis as I rule out other similar causes of what you're presenting with. So let's take heavy bleeding, for example. You've come in with heavy bleeding. As I'm examining you, I'm probably even going to look at your breasts, and you're wondering, what do the breasts have to do with bleeding? Hormonal imbalances, for example. So the examination and the history taking, keep in mind that it's to rule in on the diagnosis, and it is also to rule out the differential diagnosis, other causes of what you're presenting with. So after you've examined fully, I'll probably do a bimanual exam, a vaginal exam, and a bimanual exam. What that means is I'm basically, let me stop sharing my screen for now so that I can see you. Basically, a bimanual exam means I am examining your womb through your vagina. So my 2 fingers are in, and then there's one hand on your abdomen. So I'm basically trying to palpate the whole of this uterus in a manner like this, because we know that in adenomyosis, this uterus is highly enlarged. Why is it enlarged? Remember the inflammatory changes I told you about. So yes, I'll examine you fully. I'll do a bimanual exam. I might have to do a speculum exam, look at your cervix. Why are you bleeding heavy? Is there any other cause of pain other than adenomyosis? And then now finally, we go into the imaging modalities. So that's where our trusted ultrasound comes in. There are other modalities that are better than the ultrasound. So remember, ultrasound can be from the top, which is abdominal, or even transvaginal. That means the probe goes inside the vagina. It's a bit more accurate. Then I'd probably want an MRI. An MRI is usually more specific, more accurate for such soft tissue pathologies. And so it can even isolate in the myometrium, where do we have the endometrial cells forming a loculi, okay? And so the report will come back and tell you, okay, the myometrial layer is highly enlarged, suggestive of adenomyosis. Inside it, we have the endometrial cells, they look like this. So fine. You make your diagnosis, and yes, we are here, we have adenomyosis. So fine, how do we take care of it? How do we manage adenomyosis? And management here, and I have to be very clear, ranges from the person who does not even know she has adenomyosis to the person who adenomyosis has totally crippled her life. So it's a spectrum. So most people, by the way, are walking around with adenomyosis and will never know in their lifetime. They did a study in the UK, and it was published under ECHO, and they found like postmortem results looking at uteri of women who had passed on, had never complained of any issues, and around 1 out of 10 had adenomyosis, whether they had complained clinically or they had not complained. So you can tell that it's rampant.
Yeah.
Present itself. So if it's not presenting itself, we do not treat what does not bother you. Do not bother trouble unless trouble bothers you, okay? So then we ask you, your presentation, how bad is it? And so there's a spectrum and a stepwise approach as to how many, how many modalities we can take up, and then also which ones do we start with. So the management of adenomyosis, we're talking about management of non-specific symptoms. So you're bleeding heavy. My first instinct is to reduce the amount of blood that is coming out of you. You have a lot of pain. Before I even take care of adenomyosis, I would like to take care of your pain. So there's painkiller where we use things like mefenamic acid. Tranexamic acid can also be used for heavy bleeding, or Swaleh, okay? Iron builders or blood builders can be used to bring up your blood levels to what we deem as normal. So fine, we've taken care of the symptoms. If it's infertility, okay, can we help you conceive without, going to the extremes? So when we now go into proper management and specific management, we put it into 2 arms, where there's medical management and then there's surgical management. So medical management is a range from the normal oral contraception pills. Usually we use the combined pills, which is estrogen and progesterone. We can have the GnRH agonists. GnRH agonists are the gonadotropin agonists. So I would like to probably explain it this way. So there are 3 parts. There's a brain here, and then there's the ovary here, and then there's a uterus here, okay? So basically, GnRH agonists target the brain, most of them, okay? It's like in a house and you're trying to switch off the lights. Instead of going to each and every room, switching off the lights in each and every room, just go to the master switch it off. So this is it, okay? You switch off the master switch. So by default, the ovaries and the uterus will all respond to the switching off of the master switch. So examples of these drugs are like danazoles. There are very many in the market, okay? The use of GnRH agonists is not so much preferred because usually by switching off the master switch, hello, am I speaking alone?
Oh,
we're together.
Yeah, we're together.
Okay, perfect. I have to confirm.
Yeah.
Okay, so by switching off the master switch, basically I've sent this woman into a state of pseudo menopause, okay? Because all your hormones start from the brain. So if I shut it off all here, that means down, you're in menopause, okay? Even your periods will dry. So by default, I've helped you. Your heavy periods are now no longer there. Your pain is not there because the uterus is not responding to any hormones. But that also predisposes you to other effects usually we expect around menopause period. For example, you can easily get fractures. So there are bone issues in women, especially when you go into menopause. Yeah. We have brain issues, psychology issues. We know that some forms of depressions can come in, okay, when you're in menopause, for example, because there's no more estrogen to stimulate your brain. Estrogen, by the way, is your wonder drug as a woman. It is what makes you actually a woman, okay? Then heart issues. Estrogen helps us to keep your cholesterol in check, actually. What it does is it gives you the good type of cholesterol and it keeps away the bad type of cholesterol. So what happens when you pull away estrogen because you've shut down the master system or the main switch? That means the bad cholesterol has a chance to rise. And so that way you will notice that women who are in menopause or women who have been put into early menopause, either by drugs or surgery, by default are more at risk for heart disease, yeah. Okay? So basically that's why we don't run towards the heavy drugs, the heavy hitters. So we come down a step lower to the drugs that now target the ovaries, which are the eggs here. So just to refresh your memory, it's usually an axis, okay? You have the brain, which sends signals and hormones to your ovaries, which now send hormones that now act on the endometrial layer, giving you your monthly period. So that is always the pathway. So you can cut off at the brain, which we've already talked about. Then you can cut off at the ovarian level. Ovarian level, we're now talking about your normal contraception pill, the combined oral contraception pill. There are very many in the market. There's me, microgynon, there's so many, okay? So basically that gives you temporary relief. There is a reduction in the symptoms, for example, heavy bleeding, but of note, there are studies that are new now and have come out and have shown that there is very limited role of the oral pill in management of pain in adenomyosis, okay? So the pain here, in as much as the oral contraception pills will shut down the hormones a little bit, slow them down, they may not take care of the pain as adequately as you'd like them to. So basically you might need to combine with other painkillers that are very specific for the uterus, okay? Your mefenamic acid and all those things. Okay. Then finally, in the drug management or medical management, we now look at objects that could probably target the uterus itself. You don't want to bother the ovaries. You don't want to bother the master switch. You just want the adenomyosis to be taken care of. And so that's where we go to our trusted Mirena, or the levonorgestrel intrauterine system. Actually, the proper name is a levonorgestrel intrauterine system, but we locally call it the Mirena. What Mirena has is progesterone. If you remember, I told you estrogen is already a risk factor for adenomyosis. Now, in as much as they are both female hormones, your female hormones are estrogen and progesterone, but they kind of counteract each other. It's like the stepsisters. They're all sisters, but one is a stepsister to the other. So whenever estrogen goes up, progesterone by default is always down. Whenever progesterone comes up, then estrogen by default goes down. So here's a system where we have our estrogen up, okay? So you want to bring it down. You want to keep it in check. So introduce progesterone, which is a Mirena. So what Mirena does is it quietly sits put for 5 years, continues discharging the progesterone, which balances your estrogen levels, takes care of the symptoms, And by default, okay, you don't have to add anything exogenous. Now, that is medical management. The proper and most definite management of adenomyosis, and I have to put it out here on record, is actually surgical management. What we're doing with medical management is we are buying time. Here's a woman who's still looking to conceive. Here's a woman who still has fertility desires. So you really can't go and start talking about, let's take out the uterus, okay? So you're actually buying time. Here's a young girl, you do not know about her reproductive future, so you just want to first take it easy. But if you get a woman in her 40s, done with with childbearing, sorry, being disturbed by adenomyosis, actually the proper definitive management is surgical. So surgical, let's not just run to hysterectomy. One is actually excision of a loculi, that is adenomyosis. Fine, your MRI has told you there is an adenomyotic loculi here. It is this big. If you can clearly demarcate it, you can just go out and pull it out. If a normal myometrial tissue, the normal muscle layer is normal, why are you taking out the whole uterus? So that is for diffuse or rather isolated patches where you can go in, take it out properly, clean, close. The good thing about the uterus is it's highly forgiving, meaning should I take out a patch of it, that's a muscle layer, it regenerates itself, okay? Should I have to do surgery and take out a huge chunk of it, it regenerates itself. And that is the only reason why in, for example, cesarean section, I can cut the same place, it's very thin, and with time, it keeps growing, you know, and it thickens to a normal level, and I can come back and cut again and cut it the second time, the third cesarean, the fourth cesarean. So the uterine muscle is highly forgiving, it grows back, okay? Now, in the scenarios that you have adenomyosis and it is diffuse. Diffuse meaning it has not formed a well circumscribed patch. It is all over, kidogo kidogo, everywhere, okay, a little bit everywhere. So in that scenario, then you might not be able to go in and pick out the positive area. So you just might have to do a hysterectomy. What is a hysterectomy? Where now there's no other way, we just take out the whole uterus. Now, taking out the whole uterus does not mean taking out the entire reproductive system, because there's a difference. The uterus is just this layer, what you see, that is the uterus. Then these are your fallopian tubes, and then these are your ovaries or your eggs. And then down here, I'll come closer. What you see here, this is the entrance to your womb, which is what we call the cervix. And so a hysterectomy, there are several types. So I have to be very clear that now I'm out of adenomyosis, I'm now into hysterectomy, which was also part of our discussion. So with hysterectomy, you can decide, fine, I'm just taking out the uterus, I'm leaving the cervix, which is what we call a supracervical or a subtotal hysterectomy, okay? You will decide, this woman, she might also have issues with the cervix, just take out the entire uterus plus the cervix. Leave out the vagina, of course. So that is called a total hysterectomy. This woman is 55 years old. The ovaries might also bring her issues. Like you can see the ovary in my dummy here have swellings. So you might not be very comfortable leaving these ovaries. So you might say, okay, fine, we'll take out the uterus, we'll take out the cervix, and we'll also take out her ovaries. So that is a hysterectomy plus, okay, bilateral oophorectomy, meaning you remove the ovaries. This woman might actually have cancer, okay? The most common cancer here is usually cervical cancer, okay? And it has started to spread, and it is not enough that we remove the cervix just, okay? So you might want to extend your incision because cervical cancer spreads downwards into the vagina, spreads on the sides as well. So you might say, fine, we're going to take out the uterus, the tubes, the ovaries, and part of the vagina, what we call a radical hysterectomy. So those decisions usually are made. You and the gynecologist will sit down and you will look into the benefits of each, okay? Why am I taking out this? Why am I leaving out this? Should we leave this? Should we? Because every decision has repercussions, okay? And we don't just do things for doing sake. There's usually a reason. Why do we do a subtotal? Why do we do a total hysterectomy? There's also another type of hysterectomy, which is still a subtotal hysterectomy that is done during cesarean section. So for example, you've gone in, you've removed your baby, and there is no achievement of hemostasis, meaning you are bleeding. No matter what you do, no matter what you suture, the uterus is just pouring out blood and you're afraid you might lose this woman. So at that point, you might have to make a decision to take out the uterus, because where the placenta was, where the baby was, it's not stopping, okay? So she's still hemorrhaging. So you just might decide, fine, let's take out the whole uterus to save the mother's life. So that is called a cesarean hysterectomy. So basically, in a nutshell, I hope we understand what adenomyosis is. I've tried to summarize as much as possible. In terms of specific drugs, now that depends on the market that serves you. For example, the combined pills, there are very many. If we have levonorgestrel systems, we have Mirena, and I'm sure in some countries they have other systems, okay? There's also a newer intrauterine system other than the Mirena that has come in. It's not just the progesterone alone. I think there is a combined one. I was reading about it as I was reading about adenomyosis, but I wasn't quite sure about it. So I just thought it's worth mentioning, but I've not quite researched on it. So I'm open for questions.
So we have a question, or is it a comment, that you should speak English. So give us a layman's summary. I know that for
Okay. You people, you wait until the very end.
Okay, no problem. So I can start. No, you want to give the summary now?
I can, in 1 minute. Yeah. So adenomyosis is when the endometrial layer, which is a red layer or the innermost layer, seeps into the adjacent layer, which is a myometrial layer. So you see there's a clear demarcation there. This is endometrial, this is myometrial, muscle, endometrium. Good. So when this goes beyond where it's supposed to be, like the dots you see, that's adenomyosis. Okay? Good. Now, what can it cause? Heavy bleeding, pain, recurrent miscarriages, infertility. They range. Everybody can. Sometimes we even see new symptoms and we've never heard of them. And then when we investigate, we find, it's still adenomyosis. So the symptoms are very many. How do we diagnose? We do a normal scan, we do a CT scan, we take history, and we also examine you conclusively. How do we do treatment, or rather, how do we treat you? I think I've labored on the treatment in detail. So it can either be for the symptoms that are not for adenomyosis, like if you're bleeding heavily, take care of the bleeding first, take care of the pain, take care of counseling for recurrent pregnancy losses, and then now come in and narrowing down on the adenomyosis. Then there's medical management, which are all the things I talked about, and then there's surgical management, which are also the things I touched on. I hope that is a bit clearer.
Okay, great. I have many questions. Some that I had before, and just listening to you speak, I've also picked up on some things. I think the first question is, what else can present itself like adenomyosis? And the reason I ask that is because many times we go through a misdiagnosis or 2 or 3 before we end up at our proper diagnosis. So a woman who is misdiagnosed with DASH could have adenomyosis. I think that's what I'm trying to just figure out here.
There are many, and I'll categorize them into the major presenting complaints. So the major presenting complaints in adenomyosis are: 1, very heavy bleeding, pain during your periods, and finally, infertility. So if we look at heavy bleeding, if we look at pain, and we look at infertility, number 1 is endometriosis. Okay? Endometriosis is usually the more glamorous sister of adenomyosis. Yes. So you find this person has been treated over and over, is on management for endometriosis, and then later on it comes up that not only does she have, and by the way, they can coexist, and most of the time, bigger percentage, they do coexist because it's the same pathophysiological process. The same reason why this endometrium has leaked out. It can leak out to the muscle right next, or it can even jump and go across the border outside the uterus. So the same pathophysiological process leads to the 2 of them. So my number 1 on my list is usually endometriosis. Then of course, things like fibroids. You're doing a scan, you're told this uterus is bigger than it should be. Of course, the first thing that comes to mind is a fibroid, and the eye sees what the eye knows. So the sonographer might say, it even looks like the consistency of a fibroid. So you might be followed up for fibroids here and there, but it's still not taking care of a pain. And this actually is a personal experience. I've gone in severally to do a myomectomy. You've done a scan, you've done an MRI, and they all spoke the same language. So myomectomy is removal of fibroids, and you go in and there's no fibroid removed. It's just the adenomyosis looking at you. And so most of the time, when you go in for a big procedure like removal of fibroids, usually the consent that you take, the permission that you ask before you go in is, in the scenario that things are not what they seem inside, do I have your permission to remove your uterus? So those are conversations that you have to have had before you go in for any surgery. Then, of course, there are things like polyps. Polyps will give you a lot of heavy bleeding, same as adenomyosis. Then there are things like hormonal imbalances, just like polycystic ovarian syndrome. Usually, that gives you a lot of hormonal imbalances, a lot of infertility. So we might be following you up for something else because we saw something small in your ovary. And in real sense, it's actually adenomyosis. So the differential diagnosis, by differential diagnosis, I mean things that could present as adenomyosis are many. Because all you need is just to take one symptom and then look at what else could cause that same symptom. And there are as many as the stars in the sky.
Okay. Great. I think also from the interesting thing is from the study on the ladies who had passed away in the UK, the statistic is interesting that it's 1 out of 10, which means it's as rampant as endometriosis, yet we know more about endometriosis.
Exactly.
So you mentioned progesterone, and there's been a fad, if I could use that word, a few women in Kenya who are now using progesterone cream. Would progesterone cream work for adenomyosis management?
It will not.
It will
because
not.
Where is the adenomyosis? It's on the uterine muscle layer.
Okay.
I don't know how you're going to apply the cream in the muscle layer of the uterus. Okay. So that might not work because you need something inside that works intrinsically from the inside and not something that you can apply extrinsically from the outside.
Okay. Another question that we've had is, are there pre-existing conditions that would make it difficult to manage adenomyosis?
I guess yes, because, for example, you see, the risk factors, if we're to look at the risk factors in detail, there are some that we can take care of, what we call modifiable. For example, if it's a DNC or an abortion, cleaning that got us here, maybe you might not do it again. But there are factors that just predispose you to having high estrogen levels. And there are some women who just have higher estrogen levels, unlike other women, and that is genetically predisposed. So that you might not control for. In terms of other things that we may not be aware of, yes, uterine malformations, for example. Yeah. So there are some studies that were quoting septate uterus, okay, or bicornuate uterus. These are uterine malformations either where, if this is, let me not even draw, if this is a uterus with a septate uterus, you have a septum running across. So they were saying that people who have, it's not that a causative factor, it's just that it's a predisposition. People who have, say, a uterine abnormality may have a higher risk of forming adenomyosis. I don't know the link, but the studies are out there. So we usually just take it to the pinch of salt. There are also, for example, other conditions that may make treatment of adenomyosis a bit difficult in that it masks itself. So if, for example, it coexists with another condition, then yes, we might focus on the other condition. I'll give an example. If you have fibroids and adenomyosis, they are all coexisting. So a doctor may quickly focus and narrow in on the fibroids as opposed to the adenomyosis. Why? Because the fibroid is easily treatable. The fibroid is I can easily take it out, and then in the process realize that, wait, these symptoms have not resolved, even though I've taken care of a fibroid. So there has to be something more. Then when you investigate or during the surgery, then you find, there was something more, because you can have both fibroids and adenomyosis. If you have, for example, endometriosis, okay? you've looked and you've looked and you find, finally, we have endometriosis. Look, the ovary here has a bit of endometriosis. So you go in and during surgery, you take care of it and you remove. And yet the patient still comes to your office and says, Daktari, I know we did surgery, but I still have the same symptoms. So that should prompt you to think further. So yes, they can coexist. Yes, there are other predispositions that are genetic that may make diagnosis and management quite a bit difficult.
As we talk about genetic history, we have a question about history in family playing a role. Someone says that their grandma had fibroids and their mom the same. Her sister has adenomyosis and now she is being treated for endometriosis.
Yes, genetics play a very strong role in predisposition of these conditions. Okay. They do.
Now, one thing that I have found talked about a lot within adenomyosis communities is the adenomyosis bloat. So you know how we see women who have fibroids, their tummy tends to bloat and grow a little. Is this the same case with adenomyosis? Would a woman come in actually looking 3 or 4 months pregnant?
I missed that. My kids are a bit loud.
Oh, sorry. Would a woman come in with adenomyosis actually visibly looking sick, like, you know, with a bloated tummy? Does it have the same effect as fibroids?
Yes, yes. So a woman, actually, the cases I've seen with adenomyosis, the woman comes in and the abdomen is distended and you touch the abdomen and it is clearly like you can palpate and you can touch the uterus on the abdomen way past where it should be. And so that's one of the easiest way. But one of the very hidden ways usually is listen to the history, okay? Here is a young girl who has not delivered yet. Her pain levels during every period, and this period pain is, you know, it's cyclic, meaning every period. So it's not pain that is constantly there. So every period, either you have to admit her, and they're there, and most people usually brushed off as dramatic. My periods are usually so bad, I have to be admitted. They're not being dramatic, so that should prompt you towards dig a little bit more. I think I had a 16-year-old girl who eventually we got to know it was adenomyosis just by the period pain. I think on a scale of 1 to 10, her pain levels were 13.
Okay. So.
Hello, have I answered?
Yes, yeah. I can hear you. Can you hear me? Hi.
Hi, now I can hear you.
Okay, great. Is there anything that we should expect about a hysterectomy that doctors don't discuss? And here I'd like to break it. That's a question. So I'd like to break it down in terms of the procedure itself, the recovery, and then quality of life after that. And I would like to throw in sexual life as well. So it's 3 questions in one.
So you said the surgery itself?
So yes, the surgery itself.
Recovery?
Yeah, post-op. Yeah, recovery, and then quality of life as a whole. I know you touched on mental health, but I think I just want us to talk comprehensively about the hysterectomy. And you mentioned the radical, and then there's what people call the total hysterectomy. But how are they going to affect Esther in surgery, after, and then also my quality of life? And also, can I go home on the same day of the surgery, or is it a surgery that requires me to be in hospital for a couple of days?
So let's just talk about hysterectomy then in detail, okay?
Yeah.
So first of all, I think the womb or the uterus defines most women, okay? You're going around without a uterus. Are you even woman enough? So the decision to do hysterectomy, I should also add that it is a very last stop. Okay, you have gone through the stepwise management and nothing has worked. You have removed part of a muscle where the adenomyosis is, and it has recurred, because sometimes it does recur. Remember, the risk factors still stand. You're a woman who has had multiple deliveries. You're a woman who's genetically predisposed. You're a woman who, so the factors still stand and they still remain. And so every time I go in for surgery, I tell you, as much as I've not taken out the uterus, or I'm just doing this, I'm just helping you, it might recur. If I'm taking out your fibroid, I'm taking out this fibroid, but that doesn't mean that you will not grow another one. So fine, let's reach the decision where we're taking out your uterus. it's not reached very likely. Actually, usually they've done studies, and the mean period between the time you initiate conversation for hysterectomy to when the woman comes back and says, okay, doc, now I'm ready, let's do this. They were saying it's between 3 and 6 months. And that has taken a lot of soul searching and behind the scenes, maybe tears and all that, okay, and introspection. So basically, nowadays we have newer modalities of doing the hysterectomy, okay? I talked about the total, the subtotal, where I leave your cervix behind, where I can leave your ovaries and the tubes behind, or I can take out everything, like radically. So if you have cancer, for example, if the reason we're going in for the hysterectomy is cancer, and the cancer has started out, you know, spreading out, then there's no option there. I don't think there's anything to bargain. Why would you want your cervix left behind when it's brought in the cancer, when it still has cancer, okay? So that is a no-brainer. Why do you want your ovaries left in when they have a pathology, when there's something wrong with them? Or you are a 55-year-old woman already in menopause. So we know these ovaries are not doing anything extra for you. There are no hormones secreting. It is just actually an added risk for cancer. So the decisions become easier when the reason for entering in is very clear. Now, if you are a 35-year-old woman and you're done with childhood and you convinced me to take out your uterus, I might not take out your ovaries simply because you still have a long way to go before you actually naturally hit menopause. So I may not be in a hurry to take you to your menopause surgically quite early, okay? So those decisions, pre-operatively, there's going to be an extensive consultation to determine where do we reach, what are we going to do, how are we going to do it. Now, even after explaining and agreeing that this is what we are going to do, the consent that we seek, and usually we explain it very simply, is the body does not read books. Scans have an error margin. All the modalities, we may be thinking we do not have cancer, and I go in, I was treating adenomyosis, and I find something else. It will not be morally and ethically okay for me to leave cancer inside you or any other thing inside you, and I would have taken it out in one setup. So the concept usually we take is until where I deem fit, okay? And that's where now the patient-doctor trust and relationship comes into play, because you have to believe that I have your best interests at heart. Good. So now fine, we are going in for a total hysterectomy. So how then do we go in? When I say we go in, where are we going exactly? So it can either, if this is a uterus, we can either remove it from the abdominal root, meaning you're lying in front of me, I'm looking at your abdomen and pelvis, I open you up, okay, and I touch things and I remove by touching. Or you're lying in front of me and I use laparoscopy to take out the uterus. Laparoscopy versus open. Open is where I actually cut, I leave you with an incision. Laparoscopy is where I use tiny holes. One is usually at your umbilicus, the other two are usually on the sides. Sort of like you're playing a video game to manipulate so that you're doing all those things without actually touching. This is, okay, I'm not going to say better. There's no better, there's no worse, okay? If you're to compare the two, each has its advantages and disadvantages. So I'll probably just rush through why we may decide to do one over the other. Okay. So yes, you can be discharged on the same day if you decide to do it laparoscopically, because the incisions are very small. There's no big wound I'm leaving you with. Things are done very precise, and we go in, we go out. The disadvantage with laparoscopy, it takes more time. Trust me, if I'm not touching your uterus, if I'm not doing things with my hand, I'm just using instruments by proxy, it usually takes longer, and so by default will take much more of your finances, okay? So laparoscopy is usually more pricier than open surgery. Okay. Good. So why then, since we have the abdominal route, will I decide to go through your vagina? Because the vagina spares you any kind of incision. I am going through the vagina. I will start making my incision this way. And so step by step, my son is here. I have no go and watch TV. Go and watch TV. To say sorry. Okay. So why would I remove your uterus through the vaginal route? There are some conditions that will prompt me towards removing the uterus through the vaginal route. For example, a uterine prolapse. You see, a uterine prolapse means the muscles and the ligaments supporting and keeping this uterus up have sagged already. So the uterus has fallen on itself. Most of the time, this cervix and the uterus falls into the vagina. So actually, how do you know you have a uterine prolapse? You put your hand in your vagina and you cough, things come meeting your hand, okay? So they prolapse down. So things, I mean, the surgery is already halfway done for you if things have prolapsed, okay?
Yes.
Since it has fallen down on itself, you might as well finish the job vaginally, okay? So the decision to do whether vaginal hysterectomy, open abdominal hysterectomy, or laparoscopic hysterectomy is based purely, on the patient condition.
Okay.
If, for example, the uterus is so big, the adenomyosis is so bad, I might not want to take it out through the vagina, simply because how will it fit? Okay, it's big, because what the vagina is just this. Imagine this is 10 times the normal size. How will I force that uterus to come out through the vagina? Okay, same way, if I do not have the proper equipment, this uterus is so big and I'm going in laparoscopically, I don't have what we call a mocellator. A mocellator is like an instrument where, you see, I've gone in through a keyhole, okay, through the umbilicus, a very small hole. How do I take out this uterus to fit through the umbilicus, okay? So usually most of the time we need like a grinding machine after you've detached the uterus, now to bring it out where it grinds into smaller pieces so that you can pull them out. So those decisions usually are made depending on the patient and how the patient has presented. So yes, you can go home the same day if you have it laparoscopically. If you have it transvaginally, or if you have it abdominally, open abdominally, usually it will take you around 3 days in the hospital to fully recover. Yes, there are risks. It is a major surgery, whatever route you use. A hysterectomy is one of the major surgeries and it carries potential risks, okay? So the most common risks actually just come in by the mere fact that there are other organs, in proximity. In front of your uterus, you have a bladder. I could injure your bladder. In behind, you have your gut, okay, your rectum. I could injure your rectum. We have the ureters, which transmit the urine to your bladder. I could cut them, and it has been done, depending on the pathology. If the cancer, for example, has spread out, I may put a knife, and anywhere I put a knife, you'll just bleed out. And people have bled to death on the operation table. This is not to scare, but there are potential risks that come with every major surgery. It is a long surgery. Potentially, it may take above 2 hours. You can imagine if you're an obese woman and you're sleeping on that table for 2 hours, you're forming risk of throwing clots, okay, getting pneumonias, okay, because it's a long, prolonged surgery. And then, of course, now, post-operatively, the healing process takes time, okay? Okay. Depending on how extensive the surgery was. You can imagine if I did a radical hysterectomy and I took out part of your vagina. So the pain is, and the wound is not even comparable to, say, a laparoscopic hysterectomy. Now, I usually want to add in the aspect of emotional healing, because here's a woman who her whole life, depended on her uterus. You've just taken it out. She actually might not even tell other women for fear of being, castigated and judged, because women hold the uteri close, okay? So those are the things you're supposed to take care of. Patient preparation in terms of... Thank you. So those are the things you take care of in terms of, you have to prepare your patient. You're not just rushing to take out her uterus. How well prepared is she for that? Now, of note, and this should be the take home, the most important thing here, linking hysterectomy to mental health, hysterectomy to other conditions, that is highly dependent on if I took out your ovaries, okay? Because the minute I take out your ovaries, yes. Okay, guys, I'm doing something, okay? Can I finish? Yes. Yes. Okay, so if I take out your ovaries and say you're a 35-year-old, you're basically a 35-year-old in menopause, okay? So I have to actively take care of you like I will take care of a woman in menopause. Yes. So this basically means I, put you on hormonal replacement therapy. I put you on estrogen just basically to sustain you, keeping in mind that these therapies also come with their own added risks. So that is an entire topic on its own, hormonal replacement therapy. Okay. So basically, if I'm taking out your ovaries, that is a conversation that has to be addressed from the word go.
Okay. Do you need spousal consent?
Yes, extensive consent.
Yes. Okay. That's a question that would come up. Okay. So there's been talk about a connection between the brain and the uterus, and from what I get, there's no physical connection.
Yes,
okay.
There's no physical connection, but what connects, I call it the axis. So what connects the axis is the brain produces these hormones that induces the ovaries respond to that hormone, and in turn release another hormone. That hormone will now work on the uterus. So it's a pathway, and the connection is just hormonal, but it is not a physical connection.
Okay. I like that you mentioned that there is an excision surgery option for some types of adenomyosis. I think that's really key to take note of, because with endometriosis, we try to look for excision. So if there's an option for that, that would be really great for adenomyosis.
Exactly.
We have questions. I want us to finish with Mirena. We have questions about seed cycling. Now, a natural alternative of balancing hormones. Have you prescribed that to your patients? Have you seen it work? Sorry?
I didn't catch that. The question was on?
Seed cycling.
Okay.
Yeah. So does it work? Would it be a good option in terms of adenomyosis?
I have not done research on it, okay? I think I have a vague idea where you use some type of diet.
Yes, so you're using different seeds at the luteal and follicular phase, yes.
Yes, and so you'd assume like this type of seeds would have more of this, and then these types of seeds would have more of this. Yes. So basically it's trying to mimic the body's natural cycle where you bring the natural hormones to their levels. So I'm not going to say they don't work. I'm not going to say they work simply because I have not read extensively on them. So I cannot bring papers, may argue with papers and proof. Yeah. But I know for sure the fact that I've come across it, it has worked for some people. And yes, all these things, by the way, all the hormones you're talking about, they're found in diet. But the only question I usually raise is, how much then do you know you're taking per this amount of seeds? Okay, because if I gave you a tablet, I'm not pushing for tablets here versus seeds, no. But if I gave you a tablet, I will definitely know the amount of hormone that is in that tablet. I will definitely know the amount of whatever hormone that is in the other. Just 1 minute. Don't even go away.
Great. I hope your questions are being answered. If you have any questions or feel like there's something I've overlooked in regards to a hysterectomy, please message me. You can message me privately if you prefer. Up next, we'll discuss Mirena, not necessarily as a management for adenomyosis, but also as a contraceptive. So if you have any questions about that, that would also be great. I'm wondering, has anyone had a hysterectomy or has anyone had a hysterectomy on this chat? If you have, it would be great to hear your experience. I know there are not so many women, but there are some who are willing to share. And welcome back, Dr. Swabra.
I'm back.
Okay.
So basically what I was saying is I'll probably go and read more on this. We'll share on our platforms once we have conclusive. Okay. But you, Esther, I know you know something about it. Just talk. Don't it.
I'm not a doctor. I am here.
No, just talk. Let's share knowledge.
I say that because I've seen both schools of thought. I have friends who are very pro seed cycling and others who have said this is not working. And especially on Instagram, you can see a lot of people making a case for both. I do believe, like any medication, there could be side effects. So you're taking it cautiously. And if you're taking the seeds, I'd say keep a diary and just begin to note down all my symptoms, physical, mental, in terms of moods as well, and then actually see if it's working. But if you can get the consent of your doctor, I think that's the best thing. So I'm not calling you Swabra when I'm bleeding out and you ask me, what were you doing? Why were you doing it in the first place? but we are sort of on the same page together. In regards to post-surgery management, you mentioned something about the uterus being able to heal itself, like if we just did like excision. So are there particular foods that I should eat after having a partial hysterectomy or excision surgery for adenomyosis?
Diet.
Yeah? No diet. So just a balanced diet. Okay. No supplements needed.
I do not have like specific foods.
Okay.
Like, top of my head that would encourage, specifically muscle growth. Of course, proteins are known to help in bulking up of muscles and all that. But in terms of specifically for the uterus, not really. As long as you have your balanced diet, then all the micronutrients are needed and they're going to be availed to the body. So let's not forget that a balanced diet is actually macros and your micros. So macros is your protein, carbohydrate, and vitamins. And your veggies. And then now your micros are now your micro elements like magnesium, zinc, and all those things. So as you're having a balanced diet, just keep into account all those things. So basically foods that will enable you for proper wound healing. So a lot of protein for that.
Okay. Now I've seen this abroad and in other support groups, pelvic floor therapy. Do you advise for it floor therapy, like physiotherapy of the pelvic floor?
Oh, physiotherapy, post-hysterectomy, yeah? Okay. So the most common, scenarios where we use pelvic floor therapy is in the obvious things. For example, after childbirth and you're trying to prevent a bit of pelvic floor prolapse, if you actually have pelvic prolapse, but after surgery, when we remove your uterus, it's not just dead space left inside, okay? So where the uterus occupied, which was your pelvis, what happens is we leave what you call a stump. A stump is if we removed the cervix, the uterus, everything above, we don't just leave the vagina open into the cavity such that the next time you're having intercourse, things can go all the way into your abdomen. No, we usually close and create a pseudo vault, okay? Vault meaning like a closure, where the wound actually is, where my stitches will mark the end of a vagina and the beginning of the abdomen, because that demarcation has to be there. The importance of creating that vault is to prevent actually vault prolapse in future, because yes, this is your vagina lumen. You create your vault, and if you're not careful and you don't strengthen that vault, you don't suspend it to nearby structures inside the abdomen, sometimes the vault falls back on itself. And so that's one of the complications, long-term complications of a hysterectomy, in that you do a hysterectomy, then the woman comes back and says, Doctor, you remove my uterus. Yes, yes. So how comes I'm still feeling things coming out? It's a vault coming back on itself. So yes, you can have physiotherapy, pelvic floor therapy. Pelvic floor therapy is where the muscles that form your pelvis, okay? Usually you do either it's your Kegels or other active exercises, so that the sling or the suspension of what forms your pelvic floor and demarcating it from the abdomen is tight, so that things don't fall upon each other. I feel like I have to explain this using my pen and paper.
Okay. Have you, in your experience of doing hysterectomies, continue. Yeah.
Okay. So usually these are the muscles, okay, that form your pelvic floor, and then things like the vagina will pass across there. So you can imagine this is like a hammock. The more the hammock sags, the more things that are supposed to be up come down. So basically, when you talk about now physiotherapy and you talk about pelvic floor exercises, it's just tightening that hammock so that things are lifted up and they should remain up. You're asking a question.
About a frozen uterus, have you seen that with adenomyosis? Like frozen, everything fusing together? I know we see that with endometriosis. Pelvis. Yeah.
Yes. So that will mostly occur if the adenomyosis was occurring together with the endometriosis. Because remember, adenomyosis is limited to the uterus. It does not step outside. So what is a frozen pelvis? Maybe we're using the word casually and loosely. But a frozen pelvis is where things are not where they're supposed to be, and things are matted together, such that sometimes you open up a woman and you go, where do I start? Who is where? Where do I cut? Where do I remove? So you find that the bladder is matted on top of a uterus simply because, and adherent, like you can't even separate it, because there was a bit of endometriosis on the bladder that anchored it to the uterus. The gut is behind. You find the ovaries are no longer on the side. They've twisted, now they're on top. Like, things are not where they're supposed to be. So that's a frozen pelvis. And a frozen pelvis is a very difficult pelvis to work with. And that is why initially when I'm getting your consent, I tell you there is risk of damage to everything, simply because if I find them matted together as I'm trying to pry this away from that, yes, I could injure everything. So yes, adenomyosis by itself, maybe not, but adenomyosis most likely will occur with endometriosis, and yes, it will give you a frozen pelvis. Another thing to add is, with every subsequent surgery, the risk of adhesions and a frozen pelvis increases, simply because in the healing process, we have a lot of inflammation, we have a lot of reactive changes that occur. So where you put a knife, how you're coming out is very important, and that is why, yes, there's normal surgery for endometriosis, for other things like, fibroids, but we usually say that endometriosis surgery should be delegated to the fertility specialist, simply because there's a decorum in how you enter and how you exit that abdomen, that to leave the abdomen very clean and prevent future matting of things, because this woman is still forming endometriomas and endometriosis everywhere. This woman is still forming her adenomyosis. So if you go carelessly, leaving things, suturing haphazardly, the surgery will leave more damage, and then now the woman's natural process will even increase the damage. So the next time you're entering that abdomen may be a very difficult surgery. And let's keep in mind that these people may not require one surgery. She may need 2 surgeries or even 3 for the adenomyosis. And then the same woman will come back for a cesarean section, a second cesarean section. So this abdomen has probably been entered 5 times and above. So you can imagine if everybody was to be careless, how that abdomen would look like.
Okay, I like that. Sexual pleasure after hysterectomy, is it there? Does it change? Is a hysterectomy something that I should pause on if I'm holding on to my sexual life? How do they come together and how do they merge?
I like the focus of this question. We're asking the most important questions.
Straight to the point.
Okay, so in terms of the surgery itself, for surgery's sake, there should be no change in sexual experience. I will add, there is a role of a cervix in lubrication of a vagina, okay? So the cervix usually has glands that secrete a little bit of fluid, and so that plays a role in lubrication of a vagina. So yes, in as much as the vagina has its own lubricants, has its own glands that produce fluid, the cervix helps. And so if I take out the cervix, I will warn you that, okay, you sometimes may need a little bit of help with external lubrication, okay? Because naturally you may not be as lubricated as you would have been with the cervix. So that is one. Number 2, there is a role of a cervix in sexual pleasure. Okay, I will put it as casually and as locally as possible. When your man is inside and he hits the very last spot, what he has hit, you feel, okay, that is the very end, that is a cervix. And that plays a role in sexual pleasure, okay? Some women, that is their thing. So you can imagine this is a point where I've taken out the cervix. So that very last spot, you don't quite get a feel of it being reached, okay? Because if we go back to the definition of a vagina, what is a vagina? It is an expandable muscular tube. That vagina can expand so much this way and so much this way. There's no pain you'll ever get from it, okay, unless maybe you're not lubricated. But the cervix kind of marks the very end of where he should reach, okay? So no, he will never pass through and go to the abdomen. In terms of sexual pleasure per se, it might not change much for the majority except for the lubrication, because we also keep in mind that many women are very clitoral, okay, in their pleasure. So the clitoris is still there, nothing has been done. And in terms of future, sexual pleasure, usually it's not such a big issue, okay? I think it's all in the head first before it translates in the body.
Okay. Before we move on to Mirena, I want to ask, so when you're doing a hysterectomy, do you work with other specialists? Do you bring in a specialist now, someone who will guide the woman? Because we are treating her as a whole, not just what she's presented her uterus with. So because we've talked about the mental health as well, yeah.
Usually we have risk classification.
Okay.
So if I'm going in for a radical hysterectomy, okay? If you are a good surgeon, a wise surgeon, and not selfish, it will be best to call in a surgeon because you do not know how far up you may be forced to go. Because with the radical, in as much as I just said, you're taking out the vagina and the uterus, there is something called lymph node dissection. So usually there are the obstetrician gynecologists, and then there are specialists that have gone ahead and, for example, focused on oncology, okay, cancers. Others are focused on fertility surgery, okay? Others are focused on laparoscopic surgery. So the more advanced the surgery or the more advanced that you need to go, I would like to think that you call upon the person best suited for that. So if, for example, I'm going in for endometriosis surgery, yes, even a junior doctor can go in for it, but they'll end up doing more damage. So you're better off calling in a fertility specialist, an endometriosis, surgeon, or a laparoscopic surgeon, or if you're doing a radical, call in an oncologist. If you anticipate that this abdomen may be a frozen abdomen, I would like to go in with a surgeon so that, should I touch on the bladder, please, let there be a surgeon to help me repair. Should I touch on the rectum? That is very unknown territory to a gynecologist. Get someone to help you repair, maybe even put a colostomy bag for later. At the end of the day, it is a overall good for the patient and not necessarily for the surgeon.
Okay, great.
Yeah.
And I think with that, now we can move to Mirena. I have a couple of questions on Mirena, but let me start with the one that's not related to Mirena. There's someone who said that a friend has very thin, clear vaginal secretions every month, enough to fill a pad, and they also have a lot of cramps. Is this normal? Could this be adenomyosis, something else? Do they need to come in for an assessment?
Okay, so with every family planning, first I'll give you the ground rules so that we are clear. There's no family planning that is 100% effective, okay? Even if I should take your tubes and tie them, we still give you a percentage. It is 99 point. That means there's a chance that out of some will still come back pregnant. So the Mirena as well, okay? And in terms of effectiveness is not just prevention of pregnancy. There are other side effects that are expected of every particular family planning methods, and Mirena being one of them. Usually the most common here is pelvic discharge. There are those conditions where I will not put a Mirena on you, and so I'm not sure if this Mirena was put with already a history of vaginal discharge, because if you have pelvic infections all the time, I will keep off my Mirena simply because it is acting as a foci for all your microorganisms. I'll explain. The Mirena sits pretty inside your cavity, and so you have discharges coming down from the vagina, potentially from up here. So you don't know, every time I treat you with antibiotics, am I really reaching all the microorganisms, or there are actually some who have formed a foci into hard to reach places around the Mirena? So frequent infections or a pelvic inflammatory disease is actually one of the reasons why I will be forced to remove the Mirena, so that I can treat you conclusively and then get another Mirena and insert. So she needs a conclusive examination.
Okay, and now on Mirena, someone else has used their Mirena for 8 years. So they had it for 5 and then had it changed. It's been 3 years since the second one was put in, but they're experiencing an abnormal cycle and hormonal imbalance.
So the Mirena has not worked.
Okay.
Yes?
But not for adenomyosis. This is just as a contraceptive. It's not for adenomyosis, it's just as a contraceptive.
Oh. Okay. I didn't pick the question. Is it that she's used it for 3 years
She's
and
used it for
she
8
got
years
a
in
baby?
total. 8 years.
8 years.
Yes. But now
So that is
her cycle has changed. Hormones are imbalanced.
Oh, okay. Hormones are imbalanced. I would not attribute it to the Mirena. Of course, when you read the leaflet in Mirena, by the way, they'll say one of the long-term complications is disorganization of your menses. But if you go back to the science of it, what does Mirena have? It has progesterone. What does progesterone do? It suppresses your estrogen. What does the estrogen do usually? Most of the time, it's the estrogen that brings in the bleeding disorders. So if the Mirena has been in for 8 years, then maybe that's a problem because Mirena is for 5-year use. So by 8 years, it's exhausted. So I'm assuming if it's 8-year use, you removed it at 5 years and had another inserted.
Yes.
So if you're still presenting with a lot of irregular bleeding, hormonal imbalances, I would investigate other causes because the Mirena could be there doing its thing, but there are other things, okay? If there are big fibroids, for example, no Mirena would probably sustain and contain the bleeding. If you have polycystic ovarian syndrome, that is also another reason why you might be bleeding haphazardly, and the Mirena will probably not help much with that. So I would investigate for the reason why you're bleeding haphazardly and not be so quick to castigate it on the Mirena.
Okay. I have some questions about the GnRH, the Lupride Zoladex in treating adenomyosis. I think,
yes.
Are they successful? And do you give, because now in patient-led forums, we have a lot of backlash or a lot of side effects from these, especially bone density going down, and it's so difficult to buffer up. Lives are changed, backaches, brain fog. So do you prescribe them, and do you prescribe them with something else as well?
Okay, so with the GnRH agonists, yes, they are prescribed, and not just even for adenomyosis, for endometriosis, for fibroids as well. Sometimes we have such massive fibroids, we cannot just go in as they are. We may need to shrink them a little bit as we build up the blood reserve so that now the patient is ready for surgery. Okay. So yes, you'll be forced to use GnRH agonists. What is the protocol? You cannot use them continuously for more than 6 months for the same exact reasons you've elucidated to, because as I said earlier, and I think I touched on it, you're basically switching off the main switch. I am putting you in a state of pseudo menopause, meaning you and a woman who's 60 years are the same. I have shut off, you see, all these problems are coming because of hormones. So I have shut off the master hormone center. So that translates in everything else a menopausal woman will suffer from. What is your bone density? Am I weakening your bones? Am I, playing havoc with your brain, with your depression, dementia, all those things? Am I increasing your risk of heart attack? Am I increasing your risk of not sleeping well at night? So all those things are usually put into account, and that is why we limit the use, continuous use. You reach the 6 month, you stop, so that the woman can resume her normal non-menopause state, so that she does not enter into the pseudomenopause state. I don't know if I've answered the question. So yes, the use is there, but the side effects most of the time outweigh the potential benefits. So that is why every time you manage a patient, you approach with a stepwise approach. You start with the least harmful and you step it up. You go to the tablets, the contraception pill. If that doesn't work, maybe you do Mirena. If Mirena doesn't work, then now you can go to your Zoladex, Danazol, and all those things. If that doesn't work, let's try a bit of excision. If that still recurs, okay, fine, let's take out the uterus. So there is no perfect management. It's a transition, and some patients may need 2 actually, okay? Other patients may need 1, and every patient is different and falls on the spectrum.
Okay. I have some questions regarding successful treatment. So for the difference between adenomyosis and endometriosis would be that there is not a cure, but there is a more extensive management. Or is a hysterectomy a cure? I think that's a question that I'm trying to ask.
For adenomyosis, yes.
Okay.
A cure in that you've taken out everything. You've taken out what could potentially bother you. Because endometriosis, this is not management for endometriosis.
Yes.
This is management for adenomyosis, because adenomyosis, the ectopic endometrium is limited to the myometrium, the muscle layer of the uterus. So I mean, if I take out the whole uterus, your problems should cease. But as I say, they don't occur in isolation. Most of the time, if you see adenomyosis, there is endometriosis. And so me taking out your uterus, and I leave you with endometriosis. Where is endometriosis? In your rectum, in your bladder, we'll also take all of those out. So usually before surgery, you have to be very sure, where do you start and where do you end? How have you helped this woman? Because you might do the surgery and you think, hey, Rippy, we've done it. No, if you've left behind endometriosis, you've not helped that woman much. So endometriosis, if we're to talk about that, I think we need a forum for endometriosis, because these two things are just... So endometriosis, surgery may not be your definitive management, okay? And by surgery, I mean like hysterectomy. Because what if the foci is on the bladder? So you might need to resect that bit from the bladder, close the bladder. What if it's on the ovaries? Go get your endometrioma, close up the woman. So you probably go to where the problem is. But adenomyosis, if you're truly sure it's adenomyosis just, you can take out the whole uterus and our problems should end.
Okay. So we have, after using the Lupride or Zoladex, sometimes it cools out, like it really chills the adenomyosis and sometimes the endometriosis as well. So I've had questions regarding successful treatment after using medication, but this medication is not a cure. That's what you're saying. So if it's not working, then they would have to go back in to see the doctor, right?
Also, one interesting thing about the GnRH agonist, it gives you such nice remission of symptoms because, again, master switch is off, okay? But there's something called rebound or a flare-up when we reintroduce them back, or rather when we take away the drug.
Okay.
It's like your system was just yearning. It's like a horse that was just being held, okay? So the drug is just stopping the horse. But the minute we take away the drug, everything usually comes rearing back up more aggressively from what we've seen. So I'll give an example of, say, fibroids. You give it with a plan in your, like you have a plan, because you know you're only supposed to use it for less than 6 months. So what is the plan here? The plan is, let me get these 6 months where I can shrink these fibroids, where this woman can build up her hemoglobin level so that she's stable for surgery. Immediately I remove the drugs, we go to surgery. So the same thing, what is your plan with these drugs for endometriosis, for adenomyosis? Fine, you're giving them, it gives you a recluse so that you breathe, okay? You first stop, but there has to be a plan after that. This is a woman on long-term management. Is it that you want a child? That's why we're not removing your uterus. So what is our plan? Are you going to get pregnant immediately? So there has to be a follow-up plan. And these are the chronic conditions in gynecology. This is not a woman who will walk into your office one time and that's the last you're seeing of her. This is probably a girl you'll walk the journey from when she's 14 until you remove her uterus when she's 55 years.
Yeah. Okay, great. So how effective is Mirena in terms of adenomyosis? It's coming up, it keeps coming up. How effective is it? Will we still, I know you said that it changes the cycle.
Let me get the Mirena people here to speak of their products.
And also I've been wondering, is there an alternative in another market that we only know Mirena in Kenya? Is there an alternative in another market?
Yes, I think just after this discussion, everybody can go in and just like look up other intrauterine systems. I've seen one more. I just cannot speak authoritatively simply because I was seeing it for the first time today. But in our market, in terms of intrauterine systems that contain levonorgestrel or just progesterone, I think Mirena for us is it, okay? So how effective is it? The thing about us is we also don't do studies to say out of this number of women who had adenomyosis in our setup, we have treated with Mirena and these people went into remission, and these people did not respond to it, and so the success rate will be this and this. So I cannot give a number off the top of my head, but it will give you like a calming down of symptoms. So basically, we know it's estrogen that is a problem. So science tells me, should I introduce a bit of progesterone? It balances them out. So there is no disappearance of symptoms. I'm not saying you will never get pain. I'm not saying you will never get a period. You will get a period. It just might not be as heavy. You will probably get your normal, period pain. It might be slightly more than other people, but it might not be as bad as it was before. Okay, so in terms of a figure, effectiveness, because when you say effectiveness in science, we measure with numbers, okay? I don't have a number, but yes, it does work. It is a step towards management of adenomyosis.
Okay, I think we are done with questions. If there's one that I have not, oh yes. What natural management protocols would you recommend for those who don't want to have a hysterectomy or put in the coil?
So natural, if you go back to my initial management, remember there was management in terms of specifically for the adenomyosis and then taking care of the symptoms. So of course, painkillers, they're there. There are many. From hot water bottles, they can take care of your pain, to maybe doing yoga, meditation, exercise actually around the time you're in your periods, because of the endorphins sort of like disrupts and shuts the gates of the pain receptors. So there are small things you could do. I cannot put my hand and say, definitely, this will take care of your pain, because remember, pain is on a scale. How I'll probably approach someone who has a 3 out of 10 is not the same as someone who has a 15 out of 10. So there are other modalities depending on how the patient has presented. So the patient has presented with a bit of heavy bleeding. How do I take care of a heavy bleeding other than Mirena, other than the pills? Probably use tranexamic acid. It's not a hormone. It's just medicine that reduces the amount of bleeding. So there are other management options that are not necessarily hormonal and not necessarily surgery that I started with. We call them the non-specific management. They're not necessarily for adenomyosis. It's just any woman would come to me heavily bleeding. I would probably give that before I narrowed in on the adenomyosis. Natural methods in terms of maybe the food you eat, in terms of the exercise you do, I'm not going to say they don't work. They work, but that heavily depends on the pain scale, the presentation scale, how the patient has presented. I'm not going to say use a hot water bottle and your pain is at 15. I'm not going to say, maybe try and exercise during your, no. It depends, and it's very user dependent.
I think we're actually done with the questions, unless someone has a question that they would like to bring up now. But I have learned a lot about adenomyosis, and I look forward to sharing the information. Is there an association of doctors in Kenya who have a specific interest in adenomyosis?
I will bring that up next time we have another Zoom meeting. I'm actually going to bring that up. We're going to get an association. Okay. But there is a fertility association. And so by default, conditions that touch on fertility, adenomyosis, endometriosis, fibroids, are usually covered under that. But I guess like a specific group for adenomyosis, no, I've not heard of. But yes, I'll get back to you on that. We might even form one.
Okay. I think, yes, it would be great. And if there's a center for adenomyosis in Kenya, I've seen a lot of patients. Sometimes we go to the wrong doctors. So is there a particular, I think you mentioned it earlier, that maybe the doctor who delivered my baby, if this is not their area of specialty or interest, might not be the right doctor for me to see with adenomyosis.
And I think that's a very important thing to bring up, because we usually just assign ourselves doctors. Yes, they are gynecologists, and then they are obstetricians, okay? And we can even go further and say there are obstetricians who just deal with normal pregnancies, and then there are high-risk obstetricians. Professor Omondi Ogutu comes to mind. So everybody has gone into a sub-specialization. And I think we should respect that simply because this person has taken the time to not just look at gynecological issues, but to go ahead and say, okay, not just gynecological issues, but fertility issues to be precise, endometriosis to be precise, or cancer to be precise. So you cannot have the same gynae that delivered you 7 years ago, taking care of your cancer, okay? Let's adopt a culture where we seek the appropriate qualification for several advanced conditions, okay? Yes.
Okay, great. So we have a question. I get this painful pressure movement in my pelvis. I think this is pelvic, okay, pelvic area. I get this feeling that something is pushing through my vagina. Is this normal?
We need to examine you.
Right?
I may need to examine her.
Okay.
I don't know. I don't know what it could be.
Okay. So if
Yeah.
she's in Mombasa, she can come and see you. If not, she should see a doctor who is skilled in this area. Yes. Okay. I
Yeah.
guess if there are no more questions, we can take parting shots. If anyone has anything they'd like to say to Dr. Swabra, I can invite you to do that now, one at a time. And then, yeah, we can close before 11 o'clock. I think it's been an insightful morning. So you're welcome.
Thank you.
Anyone? Okay. I don't think
I can see the thank you. It's been insightful for me as well. I've been tickled. I'm going to read more, okay? Especially on the seed cycling. I've come across it. So yes, I'll read more, and then let's interact more, and then let's own our conditions. The conditions don't belong to the doctors. You own the condition, and you should be actually. This is what I tell my patients. If you come to me with endometriosis, I should be learning endometriosis from you because you have endometriosis. I have to see 1,000 other conditions. If you come to me with adenomyosis, you should be teaching me on adenomyosis. So on your condition, know the options out there so that things are not forced under your what? Your throat, okay? Yeah.
Okay. Are you okay with me sharing your number on this platform?
Quite okay. For those in Mombasa, you can reach out.
Yes, they're asking where to see you. Do I give them the whole list or Welkia it is, yes? Which mornings?
You can give the full list.
Okay.
No, I'll just give my number.
Okay, I'll give your number just now. We have, are there any adenomyosis specialists that come to mind that you could mention? Maybe one in Mombasa,
Yeah,
they come to you in Mombasa, or in Nairobi?
Nairobi, we have the fertility specialists, maybe not adenomyosis. Yeah. And so there are several, Dr. Nore, Professor Koigi, Kamau, there are very many, Omenge. In Mombasa, I think we have Kikwai, I think we have Yusuf Guled, I think we have Mahesh in Mombasa Hospital. I'm not yet one, I'm just a gynecologist, obstetrician. So there are fertility specialists. So probably those are the people you should approach. Yes.
Okay. I'm trying to see if I just want to put up your number so that if anyone needs it, they can take it. And if they need that list of doctors again, they can reach out to the number on the poster.
Which I'll post it down below.
Yeah. Anything else? Anyone else who has something to say? Okay. I see lots of thank yous. I want to say thank you so much, Dr. Swabra, for taking your morning to be with us. I am so grateful. I'm happy to have seen so many people online. I think we should do this more often. Saturday mornings sound great. And yes, I look forward to seeing where you go and continue teaching us as you go along. You can say your parting words and then it will be bye-bye from us.
Thank you for having me, and let's do this more often. Let's learn from each other. Thank you for having me, Es.
Okay, great. If you want the recording, please text the same number. So yes, please text the number on the flyer or reach out to me on Yellow Endo Flower, Facebook and Instagram, and I can just send you the link. I see someone in Nairobi is looking for an endo specialist. I'd say Dr. Muteshi. I know he's the one who is setting up an endo clinic in Nairobi at Aga Khan. And from me, I just say, God bless you. I pray that you will find rest. For those of you who are feeling unwell, I pray that you will find healing. I pray that you'll find a good doctor who can hold your hand, believe you, and walk with you through this journey. So Beatrice, please send me a text, and then I'll send you the number that you need to get in touch with. I'll say God bless you. Have a fantastic Saturday and see you next time. Bye-bye.
Bye.